So students, today we will start a new topic, gastric carcinoma. Okay, it's a very important topic. You see, gastric carcinoma is the sixth most common cancer worldwide. Okay, and age incidence you will see is usually 50s, 60s is more common, huh? Unless there is some genetic mutation, or then in that case it might appear earlier. Male female is basically equal incidence, slightly more male predominance is seen. Okay, and what are the etiological factors responsible for gastric cancer? See, mostly exact cause not known. There is some genetic and familial factors involved. There is gastric cancer in 10% of cases is familial also. Okay, there is microsatellite instability. There has been seen mutation in E-cathedrin genes. Okay, E-cathedrin gene mutation has been seen. Gastric cancer is seen with increased incidence in genetic or familial conditions like familial adenomatous polyposis coli, in which there are hundreds of polyps in colon occur. It increases the incidence of gastric cancer also. Same is with Peutz-Jeghers syndrome, where there is black pigmentation of oral mucosa and gastric polyps and all. So familial adenomatous polyposis coli, Peutz-Jeghers, Lee-Framois syndrome, and these are the genetic conditions which increases the incidence of gastric cancer. Other factors, there are two important viruses here which are responsible for gastric cancer. One is Helicobacter pylori. Helicobacter pylori, you see, causes gastric atrophy, isn't it? Achlorhydria and gastric atrophy. This leads to intestinal metaplasia and dysplasia and malignancy. So H. pylori is an important etiological factor which leads to chronic atrophic gastritis, metaplasia, dysplasia. The other virus is Epstein-Barr virus. It has also been shown to increase the incidence of gastric malignancy. Okay, then there are certain conditions like polyps, adenomatous polyps. Polyps, as anywhere in GI tract, if polyps occur, true polyps or adenomatous polyps, they increase the incidence of malignancy. And so is the case in the stomach. If there is an adenomatous polyp in the stomach, they increase incidence of malignancy. Then other factors are dietary factors. You see, in stomach cancer, it has been seen that those who eat a lot of salted, pickled food, smoked fishes and all, with increased nitrate content, they have increased incidence of gastric cancer. And as in any other cancer, increase in amount of fresh fruits and vitamin C decreases the incidence of gastric cancer. So smoked, salted and pickled food increases the incidence of gastric cancer. So this is dietary factors. Then you have other factor is radiation exposure. You see, those who have been exposed to radiation, as in Hiroshima and Nagasaki bomb blast and all, there the incidence of gastric cancer has been seen to be very much increased. Now, obesity is also a risk factor. Another important risk factor is a previous gastric surgery. So, see, for peptic ulcer, if patient had some antrectomy, partial gastrectomy, or what happens that you anastomose it with a loop of jejunum, bile goes there, bile reflux gastritis occurs, which can lead to intestinal metaplasia and dysplasia. So previous gastric surgery also increases the incidence of gastric cancer. So to summarize, the factors are genetic factors, which are E-cathedrin gene, microsatellite instability, and there are various familial genetic syndromes like familial adenomatous polyposis coli, Peutz-Jeghers syndrome, Lee-Framois syndrome. There is increased incidence in these conditions. Then you have adenomatous polyp, previous gastric surgery, and you have two viruses, Epstein-Barr virus and Helicobacter pylori, which increases the incidence of gastric cancer. Then you have dietary factors, which I told. then you have radiation exposure and obesity, and these are the factors which increases the incidence. Pernicious anemia also. Pernicious anemia is usually associated with gastric atrophy, metaplasia and dysplasia. So you remember these are the etiological factors of gastric carcinoma. You see, these days it has been seen. Here the most common site is antral carcinoma. Antrum, the location, this adenocarcinoma mostly occurs in antrum, but nowadays the proximal migration is seen, especially in Western countries. The proximal cancer of the proximal stomach is more common. Proximal stomach means fundus, upper part of body, cardia. This part of an incidence of gastric carcinoma in these part are increasing as compared to the antral carcinoma. But previously antral was more common, and still in India it's the antral carcinoma. Now, how do these patients present to you once they have gastric carcinoma? See, in early gastric cancer, the patient can be asymptomatic. They do not have any specific symptom, and slowly they might have symptoms resembling peptic ulcer. Okay, so you can't differentiate on clinical basis that this is peptic ulcer or carcinoma in early cases. It can mimic that also. Patient can have epigastric pain, patient can present with melena and leading to weakness, anemia. Okay, patient can have obstructive symptoms depending upon the location of the tumor. Suppose the tumor is located at the gastroesophageal junction and it is causing obstruction there, then patient will have vomiting soon after food. If carcinoma is there in the body or in the greater curvature, then you will not have obstructive symptoms. Patient will only have, maybe have pain, anemia, asthenia, weakness, anorexia, these conditions. But if malignancy is situated in the antrum and pylorus, it can later on cause gastric outlet obstruction. In that case, the patient will have early satiety, feeling of fullness of abdomen, bloating, and after 2 to 3 hours after food, patient will have vomiting, a projectile non-bilious vomiting, as we discussed in gastric outlet obstruction. So malignancy is also a cause for gastric outlet obstruction. So the presentation will depend upon the site also and the stage also. Earlier stage may have very asymptomatic or very few symptoms, whereas late cases can present with severe symptoms of vomiting and dysphagia, weakness, severe anemia, hematemesis, melena, okay, things like that, and also the symptoms of metastasis. Suppose a stomach goes to liver and involves liver, then we can have jaundice. Patient can develop hepatomegaly, jaundice. Patient can have ascites, and then these things can happen. Now, these are the symptoms. What are the signs which will happen when you examine these patients? When you do a general examination, you might find that patient is pale, pallor is there. See, a stomach spreads by all the routes, by lymphatic, by hematogenous route, by local invasion, by through the transcoelomic spread in the peritoneum. And lymphatic spread is very common, so much so that perigastric nodes are involved, which goes to celiac and paralytic nodes, and sometimes even left supraclavicular node, that is troisier sign, can be positive. Node in the left axilla, that is Irish nose, can be positive. Node in the umbilicus, which is called Sister Mary Joseph nodule, can be palpable. There may be signs of superficial thrombophlebitis. When you examine, that is called Trousseau's sign. Because of the coagulopathy, this patient can develop superficial thrombophlebitis called Trousseau's sign. When you examine abdomen, if the abdomen might be distended, if there is gastric outlet obstruction, and the stomach, greater curvature of the stomach boundary, if you do a percussion, it will be lower down. There might be a palpable lump present, and we often say when there is a palpable lump in the abdomen of the carcinoma stomach, then it is a bad sign. It means it's an advanced disease, and usually it is incurable. So if a carcinoma stomach is palpable, it's not a good sign, it's a bad sign. It means disease is advanced. In abdominal examination, you can have hepatomegaly, hard nodular liver suggesting of mets from liver. You can have palpable stoma. You can have ascites. Okay, when Sister Mary Joseph Neduli, when you do a DRE, there might be some peritoneal deposit. There might be collection in the pouch of Douglas in front of the rectum. In females there is uterus, isn't it? So in that pouch, which is called pouch of Douglas, or in male there is a rectovesical pouch, you can have some collection of metastatic cells there. When you palpate it, there will be some filling, some solid structure will be there, and it appears like a shelf. That is called Bloomer's shelf. Bloomer's shelf. That is a sign that malignancy has got transcoelomic spread and malignant cells are deposited in the rectovesical pouch or pouch of Douglas. So this is what you get in clinical examination. Next lecture we will discuss about investigation and all. Thank you.